Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a podcast show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry.
Welcome to Pedo Teeth Talk, where we're here to talk about contemporary issues important to you in your practice of pediatric dentistry. We care about the dentistry for children improving all the time, and we're thrilled to be here today at the annual session of the American Academy of Pediatric Dentistry in Honolulu, Hawaii. And we're not that disappointed that we're inside in the exhibit hall at the Tech Bar, not seeing the sun and the waves, because we have the world's experts on various topics. And I'm Joel Berg, host today of Pedo Teeth Talk, and I'm thrilled to have with me today Dr. Nestor Cohenca of Seattle, Washington, with whom I've had the pleasure of working for many years. One of the great endodontists. If you need a root canal and you're in Seattle, call this guy. Okay, and anything related to the Pulp. Dr. Cohenca also happens to be the president of the IADT, the International Association of Dental Traumatology, and as you know, the APD has adopted those guidelines. And
2013.
Nestor, welcome. Thank you for being here today.
Thank you for having me.
And I want to talk about a few things today. We're going to talk about traumatology. We're going to talk about the association. If we have time, and we'll make times, I want to talk about vital pulp therapy.
That would be great.
Because you spoke about that today, and there's so much to talk about there. So I'm going to try to cover a lot in the next half hour or less. So first, let's talk about this meeting. I want to put in a plug because all of us can go to the World Congress of Dental Traumatology. It's on August 15th or 18th in San Diego.
That is correct.
Maybe tell me a little bit about the meeting.
Well, the meeting is going to be the first time that the IADT has been actually joining forces with a U.S. large organization like the AAE in this case.
So the Endo Association, okay.
Correct. And actually the idea was actually born from the AAPD, AAE.
Oh,
if
yes.
you remember
The summit
meeting,
in
the
Phoenix,
summit
I think,
was in Scottsdale, correct?
Scottsdale,
2012.
Yeah. Uh-huh.
So actually that's kind of where grew up from, and we developed a very large program. The World Congress is being held every 2 years, somewhere in the world. The last two, just to give you an example, were in Turkey and Brisbane, Australia. And this time, as president, I brought the Congress here to the U.S. and proudly to basically have the support of the AE and the APD in many regards. And hopefully this is going to be the largest and most well-attended World Conference in dental trauma in the world.
I think it's fantastic the fact that the APD now recognizes the expertise that and the work that went into creating these trauma guidelines, and that they have just said, let's go to the experts. They said this, we adopt those guidelines. So maybe you could just talk about how these guidelines were developed. Tell me a little bit about the process and what kind of work went into creating these trauma guidelines.
So traditionally, the guidelines were created and developed by the IADT Board of Directors. Basically, that was the way it was till 2016 were created. And they were discussed every 2 years, of course, whether or not there's new research, supporting either a change or no of the guidelines available at the moment. In 2013, I believe, is actually when you were president of the APD, is that where we got that connection in which the AE has been already endorsing our guidelines for probably 15, 20 years. And the only disconnection was the APD, because they were not only recommending some minor different approaches, but also even they were classifying the injuries in a different way, using an Ellis classification, for example, which is confusing.
Yeah, we don't talk about that anymore, right? That's gone. No more Ellis classification.
Right.
Got it.
So basically we want to name and term everything with the same term. I mean, we need to speak the same language.
Right.
And we need to call the injuries the same way, and we need to, treatment plan and diagnose in the same way. So we need that understanding. So that's when the APD kind of merged and joined forces. So right now it's the IDT doing all the research and work, and then the AE and APD basically reviewing and endorsing, hopefully, in the future as well. 2017, when I took over, I decided to change the protocol of how it's being developed. So instead of having the board,
changed
correct,
a little bit, okay?
Dramatically actually, not a bit. Basically, I appointed a committee that is in charge of reviewing the evidence-based in trauma that is being published constantly. I mean, all the time. So, and then basically it's combined by 8 people from different specialties, different parts of the world, different background, mostly scholar researchers, clinicians, and they are in charge of basically providing a report to the board, whether, before it was just the board discussing this. So right now we're going to have a very evidence-based paper recommendation by this committee that will be discussed at the board meeting and hopefully approved for the new publication. So I can tell you that during the last year, we've been working in the new guidelines that are going to hopefully be approved in August and will be hopefully released, a few months later. And there are quite a bit of changes in the new guidelines because I'm part of that committee, so I can tell you that there are a lot of changes coming up.
Can we get a sneak preview today?
Sure.
Get a scoop here. What kind of changes are we going to see in these new guidelines? I want to know a few.
Well,
I want Pedo Teeth Talk to be the scooping place for these new trauma guidelines.
Definitely, it's going to be the first time I'm talking about this openly.
First time, right here. You heard it. Let's hear them.
So, for primary teeth, for example, one of the still discussions we're having are the need, for example, for CT or imaging.
So primary teeth.
Correct. Because there is a part of the guidelines that is for primary teeth, and then there are another part that is for permanent teeth.
Right.
So for primary trauma in primary teeth, the whole concept of the gentle, campaign, which basically is as minimal as possible, imaging and dosimetry to children, is basically one of their main things we're taking into consideration. So with the new digital technology, we have lower dosimetry.
The radiologists thing.
Correct.
Yeah. Mm-hmm.
So, but still, we wanted to, right now, for example, we had in the previous guidelines to take occlusal images. We don't do occlusals anymore. It's just a lot of radiation and a lot of information. So we're basically mostly right now changing in few cases where necessary. We do recommend more CT if available, because again, these are worldwide guidelines for the entire world, so we need to make something that's affordable.
So give me a circumstance, just so I can put in context of practice for a pediatric dentist. You said primary teeth, you're recommending maybe some more image.
For example,
CT. When would I do that?
An intrusion, for example. There are some intrusion cases in which you don't even see the tooth. You don't even know sometimes if the tooth has been avulsed or is intruded.
Okay.
And in those cases, for example, if it's intruded, the impact or the position of that intrusion in relationship to the permanent tooth is critical.
Okay.
So you can get that on a PA on a two-dimensional. There you go. So that's going to be, for example, a change. Intrusion, even in primary teeth, we're going to recommend CTs from now on.
So what so they're going to recommend CTs.
Most
pediatric dentists, I think, don't have a CT in their practice. So what do we do?
So basically, it's going to say the guidelines, in order to cover everyone, not put anyone under the standard of care, it's going to say basically, if available, a CT should be considered for diagnosis.
That's a big change.
Big changes.
So this is the first time you said this?
This is the first time I'm saying
that's
this.
A big deal. That's a big deal.
Yes, so that's going to be primary teeth. That's basically most, kind of the big change. In permanent teeth, there are many more changes as well.
Can you just share one or two of those, maybe one of those?
Well, let's say in vital pulp therapy, meaning in traumatic injuries in which there is an exposure of the pulp, most of the therapies right now are going to be recommending using MTA, bioceramics, or biodentine versus calcium hydroxide, it was in the past.
Okay.
So for partial pulpotomies, direct pulp capping, cervical pulpotomies, all of it will be with more contemporary biomaterials rather than, old or, still relevant, but perhaps not as good as the new ones.
So that's a big deal. When I think about, in your expertise of vital pulp therapy, and I was going to ask this later, but I'm going to go ahead and put it in right now since you mentioned that. Most pediatric dentists, most practices, and I bet you if we surveyed people at this meeting, they have calcium hydroxide in their office. They have zinc oxide eugenol in their office. Should I throw those away?
Pretty much.
Both of them. Just get rid of them.
Pretty much.
So,
yes.
a lot of, especially people who've been practicing for a while, we learned on those products.
That's true.
And, you become emotionally attached to the idea that this is the way it works, and if I don't do this, I'm doing the wrong thing. So you're telling me today I should use MTA.
That's true.
For all the circumstances where I use those, use
MTA or MTA compounds, meaning
compounds, yes.
There are a lot of similar products to MTA based on the same composition with minor differences. Most of them right now I would separate in three different categories: MTA, the original composition, bioceramics, and biodentine.
Okay.
So basically biodentine is the only one. It's a little bit different, more based on silicates, but right now, all of the three, especially MTA and bioceramics, because there's not a lot of research still on biodentine, although it's very popular because they are marketing very strongly, but there's not a lot of research about it. So a lot of the products we're using more is MTA, and we have plenty of MTA
now I saw this
right
meeting,
now.
there are 5, 6,
finally,
it was
it's emerging.
Exclusive. Now,
finally.
and the price went down, right?
Right. In 2015, that happened because actually a company that bought the original rights, actually, they has exclusivity. And
the Root ZX, you mean?
No,
was
ProRoot, which was Dentsply. Dentsply had the exclusivity, and that was very expensive. And then when they lost their exclusivity in 2015, basically the price has dropped because right now you have many companies
So
competing.
I think, Dr. Cohenca, I'm going to call you Nestor today.
That's perfect. Thank
Nestor,
you.
we need a stronger message, I think, because I think it's
agree.
really powerful, and I'm thrilled that the IADT is going to come out with guidelines that say, let's start using MTA once and for all, because we're all teaching this in our programs, and I think we need a message that says, no, use MTA.
That's true.
Strong, because it's kind of been, I don't know if you agree, I think the message, the science sounds like it's been clear.
It's
and that's
very
why
clear.
you're changing
It's
the
very
guidelines.
clear.
The message hasn't been clear.
No.
The message
Correct.
needs to be, get rid of
Correct.
that, do this.
Correct, and it should be endorsed by the big, organizations in the world, including the IDT, the AE, APD within the U.S. and everywhere else. But yes, that's the idea, and we will support every change in the guidelines with very strong scientific evidence.
I would suggest, and maybe I'm being out of line, but as a result of that meeting in August in San Diego, maybe a memo gets sent to all the program directors of the pediatric dentistry programs and says,
I will be more than happy
under
if
these
they-
situations, we recommend strongly that you, based on these guidelines that were developed based on science, that you no longer use calcium hydroxide or zinc oxide eugenol,
That is
that
correct.
you use MTA.
That is correct for trauma, and that will be easy because there is going to be hopefully not only a guideline by the IDT, but those guidelines are going to be endorsed by the APD, so it's going to be very natural for the program directors to start basically using and following those guidelines. But it also extends to vital therapy from caries exposure and other. So the pulp is still the same. The reasons for the exposure might be different, but still from a material perspective, we're still talking about the same materials, which are extremely biocompatible. But the main key of the success of this material is the sealing ability and prevention of sealing. Is
Those
the whole
three
thing.
materials you mentioned before are all sealers.
It's all about seal. It's all
nothing
about
to do
seal.
with, it's not about what we used to say, we're regenerating pulp or any of that business.
If they do, that's going to be a
Nice
plus,
thing.
but a nice thing to have, but definitely not needed.
But it's
what
the
you
sealing,
really need.
the seal is the deal.
The seal is the deal.
The seal, that's your button right
Just-
there. The seal is the deal. Okay.
Right. You'd have
We
to
came up with a
prevent
slogan.
bacterial leakage. That's the whole
So-
deal. The pulp can recover from everything else pretty much, beside microbacterial leakage.
I love this. I'm excited to see that release, and I really strongly recommend a very powerful, not even a recommendation, but like this is what you should be doing.
That is true.
And I'll work with you on that if I can help. So any other emerging things coming out of these trauma guidelines?
Yes. So that regarding crown fractures and pulpal exposures and pulp therapy, regarding a lot of changes actually in the field of luxation and avulsions. A lot of changes.
Such as?
One of them, for example, we already dropped in 2013 one of the recommendations, which was to soak the teeth in fluoride, for example.
Where did that come from?
Well, it comes from a paper in 1973 from a group in UPenn, actually, stating that soaking sodium fluoride will prevent resorption, which is completely unbased. There's just one research. It was kind of there, and I took it out in 2013.
You're saying we all did this based on that one paper?
We were recommending. I don't think many people did it in real life, but it was in the recommendation. So I actually took it off. I suggested taking it off, and thankfully they agree with that.
So we're cleaning up things a little bit.
So right now we're not recommending sodium fluoride. We need to also short, the steps that are completely unnecessary and focus on the ones that are critical. So another thing is, for example, new research in 2015 was published about soaking the teeth in doxycycline, especially immature teeth that were avulsed. We were supposed to soak them in doxycycline for 5 to 20 minutes before reimplantation. All those studies were done in animals, and animal studies in dogs and monkeys at the time. No human study was done. So in 2015, there was a retrospective study published in Sweden, which actually evaluated more than 500 cases, and they saw that there's no difference in the revascularization potential or the outcome of the reimplantation, whether or not you're soaking doxycycline.
So that's dropped.
So that's gonna drop. That's gonna drop.
Wow,
so that's dropping also.
This is late breaking news here. This is good stuff.
And more. We will drop, for example, recommendations. Normally general recommendation in all, luxations, from subluxation, luxation, avulsions, we always recommend a soft tissue diet. That's going to drop also. There's no logic in the world to recommend soft diet, actually. Sorry, as I said, soft diet. So basically that goes
There's so many recommendations in dentistry that are based on the way we've always done it.
Yes, and
now we're making it reality.
You have to thinking out of the box, basically, in order to understand, and I can share more about
big deal.
that. A lot of big deals. And the other one that is going to be a big deal is going to be, hopefully, we're not sure because that is the only topic that is still it's controversial, and half of the committee approve or promote or support one idea. The other one is that the threshold of extra dry time, which has been set for 60 minutes forever, has basically no support in the research, in the literature. All the research available, which is not many, but there are like 5 or 6 research papers well done, are actually pointing at the threshold of dry time of evolved teeth to be within 20 to 30 minutes. So basically after 20, 30 minutes in dry time, I mean, there's no change for the PDL to recover. So we're basically giving anywhere that is between 30 and 60 minutes, we're giving a false expectation to the parents and hoping that something will happen when the periodontium will
So are you saying that
won't happen.
Are you saying that the new guidelines are going to say that if that tooth's out of the mouth for a half an hour, don't bother?
No, I won't say that. No, never. You still need to reimplant.
Okay.
But it's going to be a different protocol for reimplantation.
Okay.
It's like right now, if you look at the protocol for 60 minutes in dry, or more than 60 minutes in dry, the protocol is different. So there are basically 3 different categories in evolved teeth. One is if the tooth has been reimplanted right away outside of injury, which is always the best.
Yep.
The second one would be if the tooth has been reimplanted within 60 minutes in dry, and that's again the threshold which we're hoping to drop to 30. Or the tooth has been in a biological storage medium for a few hours, but still the cells being preserved. And the third was kind of the worst case scenario in which teeth has been in dry for 60 minutes, which right now we're going to drop to 30.
So that's a big
still
change.
we're reimplant because these are,
Okay, so you're basically changing
children,
the 60 to 30.
Correct, but we're giving a much realistic expectation to the parents. We're already start planning in those cases what's going to be eventually completely necessary, which is the decornation of those teeth eventually. So we still think there is a benefit of reimplanting those teeth in 7, 8-year-old children until they start basically creating harm, which will be when they start their growth spurt. And that's when we normally recommend the second step.
I'm going to sidebar into decoronation because you mentioned it here. Can you tell me a little bit about that? And so first of all, tell me what it is. We all kind of know, but tell us from your...
So decoronation basically is a procedure that, again, was first recommended in the 80s. And the idea is that when you have, it's indicated for teeth with replacement resorption or ankylosis in children and growing adolescents. So basically the idea is what are the options when you have an ankylosed tooth? So do nothing will basically, the tooth will remain anchored to the same position it was reimplanted, while it will actually prevent the premaxilla from growing. So the whole facial growth of that patient will be jeopardized. So the other options were, extracted, but to extract an ankylosed tooth, you basically remove the whole cortical plate.
And the dust, it's all dust coming out.
And you never recover that. So those cases were, 100% of them needed a major, probably 2 to 3 step grafting procedures before those teeth would, be able to get an implant or a permanent rehabilitation. So decoronation basically comes to stop that and provides basically a better alternative by saying, okay, so if the root is anyway being replaced by bone, that's the process of replacement, right?
Yeah, knowing that's going to happen, yeah.
No, it's going to happen, it's happening, and the only 2 things that are going to in some way irritate or stop that procedure are the root canal filling, which is going to act as a foreign body reaction when the osteoblast reaches, and the crown, because bone, of course, the ridge cannot grow coronal or buccal to the crown. So by removing the decoration, that's the whole principle, is you remove the crown, you decoronate, you leave the root structure, then you remove the root canal filling material and fill it with just the blood of the patient. Basically like an extraction. You don't want to leave it dry socket.
It's kind of guided regeneration.
Yeah,
in
a way.
Guided bone
and then you
regeneration.
close. And what happens is that right now, without the crown, without the root canal filling, the root will basically be continued to resorb and replaced by bone. Eventually, after 2 years, you won't even see that the root is still there. It's going to be completely gone.
It's facilitated bone preservation.
But at the same, not only preservation, if you do it at the right timing, which is immediately at the initiation of growth spurt, and it's deferred, every patient is different, but mostly there is a big difference between genders. In girls, you need to start earlier than boys, and you have a shorter window of time. Basically, you can actually gain, not only preserve, you can gain coronal and buccal bone coronal to those root structures that you're leaving.
Wow, that's fantastic. Now, as a pediatric dentist, should I be doing that?
Well, you could. I've been teaching your residents to do it. So your residents are doing it.
We
did a lot of decoronations in the pediatric practice in University of Washington. I mean, I've done with...
Or we could refer to an endodontist who could do it.
Quite honestly, yes, but unfortunately not many endodontists are doing that either.
Okay, that's a good one to know. And I want to pause for a second and say we're here at the AAPD meeting at the annual session in Honolulu, Hawaii, in the exhibit hall at the Tech Bar. And we're recording our podcast. At the end of this podcast, in about 10 minutes or less, I'm going to invite any people here in the audience to ask a question. Don't have to be questions, but if you have some, you have the chance to ask the expert on this subject. We'll get your questions later. So I'm going to come back to you, Nestor, And there's so many things I'd love to talk about. We have limited time. I have to have you back on the show if you come back another time.
Please.
We can do it up in Seattle or on the phone or whatever you want. I saw you have a new app, a dental trauma app. You can download it. I have it on my phone.
Yes.
And you can get it on an iPhone or the preferred phone, the Samsung.
Yeah, perfect.
But anyway, you can get it on your phone. So tell me about this app. I love it, by the way.
This app, actually, the concept of creating an app started about a few years ago. But we understood there was an app actually previously, but it was a paid app. And that app never really took off, never was successful because people need to pay. And if you pay even a few bucks, it's still going to detriment people from doing. I mean, everything is free. You say, I get to try. If I don't like it, I'll delete it.
Right.
But, and second of all, it was not strategically designed to be like a snowball effect, which is what it needs to be. So we at the IDT changed that, recognized that problem and said we need to create an app that is going to be free and is going to be, mostly for non-dental and non-healthcare providers, but mostly for parents, teachers, coaches, paramedics, nurses, where accidents really happen, and have them have this in their app so they can use it and get immediate
I like
help.
the paramedic thing.
Yeah, everything. I mean, we have a lot of research. Even physicians in the ER, quite honestly, need that.
Yeah.
So we developed, and the idea was, again, the main part is actually for patients, for parents, and there are two components. One is what to do in case something happened, and then you get inside and you see the different type of injuries, so you cannot, and it's all in lay terms. So instead of avulsion, we use the word knockout tooth. Instead of fracture, complicated crown fractures, we use broken teeth. So everything, and then you see the image, and you can see your child or whatever is injured in front, and recognize what type of injury is that, and then you click there, and you will get a 1, 2, 3 steps. Moreover, in the near future, we're going to add geolocation, which basically you can say, find an emergency care or a dentist near me. And you can be anywhere in the world, and basically you will be able to search and find anyone that is close by where you can go and seek help.
And you can get and Amazon will deliver a new tooth in 2 hours.
No, not yet. We need the real tooth and right away. But that's the concept. There is another component which is for professional, but that's completely secondary. And the second strategy is to make it viral, to make it so basically the job is to everyone here to download, and more important than download is to start referring that, and you can refer that by email, text message, Facebook, Twitter, WhatsApp, anything.
I love this. I think, so you have the new guidelines, you told some exciting things that are happening, you have a new app. I hope that gets promoted broadly. I think everybody here, we should tell every one of our patients, families in the office to get this app on their phone as part of every visit. We should tell our schools. We can be
everywhere.
We can be the messengers.
Absolutely.
So we will do that. We will do that for you.
And just to make a number, the previous apps, got 3,000 downloads over a period of 10 years. Yeah. We released it 4 weeks ago. We have around 12,000 in less than a month.
We're going to get another 5,000 for you today. Watch
that
this.
Would be great.
Okay.
Thank you.
So tell me a little bit. What else is the IDT doing besides the app and the new guidelines? What are some of the other projects of the Traumatology Association?
We're encouraging more research in some fields.
Yes.
For example, like I was talking before, probably not in the 2018 guidelines, but in the future guidelines, you will see more and more actually protocols or recommendations leading toward immediate physiological movement or function of the teeth, rather than putting them on splint or for weeks. Right now, you will start seeing more active splint, meaning splints that are actually doing, in a way, you have to relate this to orthopedic and neurosurgery, physical therapy after an injury. We know that from those fields of medicine, there are no more casts. Right now, we're having boots. There's no more putting a patient after a knee replacement or a hip replacement. They don't spend more than a couple of hours in bed after the surgery before they start.
Get going. Yeah,
correct.
Get going.
So that is completely a concept that we never did it. So even if you put a flexible splint, the child or the patient will never actually take a bite with those teeth because it hurts. So we need to start right now changing the philosophy and say, well, actually, we don't need a splint. We need actually an active movement.
Function. You need function.
To encourage more healing rather than atrophy.
Right.
And that's what we're right now doing a lot of research on.
So it's along with the rest of the body.
Probably
in
a few years, we're going to have more. Right now, we completed already a few animal studies with amazing results. I can tell you that already. And right now, we're moving
You've done a lot of animal studies yourself. I know
that is correct. And this is one of the ones that I did.
You've done a lot of those studies.
Yes, yes. And we basically put braces actually immediately after implantation.
Yeah.
And the results were impressive. They didn't develop replacement resorption comparing to the passive splint, which they did. So we need to do more human studies. I think that's where we're leading on.
I would say that in the area of vital pulp therapy and traumatology, the areas that we're talking about today, there's probably been more change in people who are in mid-career or late career in pediatric dentistry relative to what they learned in their training than any other area of dentistry.
Well, in endodontics as well.
Everything's new. All bets are off.
I was trained in the 90s, and I don't do what I did in the 90s. I don't do what I did in the 2000s.
Right.
I mean, it's an evolving field, and you have to evolve with it. If not, there's no option.
I want to ask just a couple more things in the remaining minute or two we have here. Revascularization.
Yeah.
Another term and technique gets thrown around, and maybe let's just not forget to talk about that. And what is it, and who should be doing it, and when?
Everyone should be at least knowing about it. I'm not saying doing about it, but be knowledgeable about that option. It's done in immature, young, permanent teeth with a necrotic pulp. If the pulp is vital, you will always go with the pulp. You will preserve the pulp.
MTA, etc.
Correct. Yeah. I mean, you keep what is there, but if the pulp is already completely...
A dead pulp and a young permanent tooth.
A necrotic pulp will be the right term.
Okay,
with apical periodontitis and infection, and a very immature tooth, then basically you have only two options. Apexification, which was the old-fashioned way, or try to basically bring new cells into that space after you disinfect. So the whole principle is get inside, disinfect that space, and then try to bring cells into that space in order for those cells to regrow.
It's kind of like decolonization in the sense that you want to bring blood in there, but for different purposes.
Right, for different purposes. Here, you are trying to basically, regrowth the pulpal dentinal complex with odontoblasts, which is where we're not there yet. So we get revascularization, but we definitely do not get regeneration, which would be the same, like growing pulp, basically. We're not growing pulp.
Apexification is still in order?
It's still in order in case in which the root is mature enough that you can still do something more predictable, because revascularization is still, in a way, a little bit unpredictable. There are just too many techniques, too many ideas, too many concepts evolving all the time.
Yes.
But I think that still, in some cases, is the way to go when the root is extremely short and immature. And yet again, we need to know what we're trying to achieve.
What you said in the beginning is most important, that we need to know about it.
Exactly.
We all need to understand, and as the science evolves.
Those teeth do not need to be extracted. We have several options.
We have options.
And we need to, again, be realistic to our expectation. Are we going to get a new pulp? Probably not. Not anytime soon, at least.
Right.
Until we start.
But you got to start somewhere.
But we get repair. Get repair, which is more like a bone-like tissue, cemented-like tissue growth, which is, for any functional purpose, is equally great. So it's moving up.
Apexification, if I'm doing that, still calcium hydroxide?
No way. No.
How am I doing that then? MTA?
No, MTA only.
So tell me quickly, 30 seconds, how do I do an apexification?
You just disinfect the canal. That's the key again. And then you seal the apex.
With sodium hypochlorite?
With sodium hypochlorite, but it's not about the irrigant and the solution. It's not about the chemistry.
Sorry, I took some of your 30 seconds, but go ahead.
And then basically you go ahead and seal that apex. And if there is enough length, you don't need to go through any revascularization.
So I'm packing it all the way down from the top down to the apex?
Just 3 to 4 millimeters, and then you fill the rest of the canal with anything you want, or you can reinforce that with a fiber post.
It's like doing an apical root canal with MTA.
That is correct.
And that's why,
that
eliminates, that's why I need an endodontist.
And that eliminates 18 months of replacement of calcium hydroxide, which was the typical way of doing apical.
You're done.
I'm done.
Yeah,
I'm done in 60 minutes.
You're not done here, but you're done with the procedure, I mean.
I'm done with the procedure. That is correct.
That's great.
And you can restore the same day.
That's great. Well, I want to thank you, Dr. Cohenca, for being with us today on Pedo Teeth Talk. We're here live, and we do have the chance to take a question or two. If I see any questions, we'll take them. If not, I want to thank our audience. I want to thank all of you who are listening to this recorded. On behalf of the American Academy of Pediatric Dentistry, you just listened to Pedo Teeth Talk. Up-to-date information, and today we had the chance to talk to our expert, Dr. Nestor Cohenca, endodontist from Seattle, Washington. Thank you very much.
Thanks for having me.
Take care.
Thank you.
Pedo Teeth Talk is brought to you by the American Academy of Pediatric Dentistry, the show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry. If you have any questions or comments, please email info@aapd.org. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.